Okay, so I think we can move on. Thank you very much. It was really very nice to have all these details of the study, and we'll have, I think, many questions. Some are already coming in the Q&A button, so please continue to send questions while we present our slides, because we'll have some time at the end to answer these questions. So let's now see what could be other therapies of anemia, as you mentioned, Aaron, at the end of your talk, and what can be the place of luspatercept among them. For a while, we used to apply this algorithm proposed by Paco Cervantes many years ago to treat anemia in patients with myelofibrosis based on their endogenous EPO level. So you measure the EPO level in the blood of your patient, and if it's low, then it's proposed to give a EPO or an ESA. And if it's high, or let's say adequate, then it was proposed to use androgens and danazol in particular. So this was also, let's say, acknowledged by the more recent NCCN guidelines for the management of MF-associated anemia, where it's important, of course, to rule out other causes, because these patients, and as Aaron said, may have many other reasons to have anemia, not only directly disease-related, but they can have bleeding, especially those who are also thrombocytopenic. They can have iron, B12 folate deficiency. Hemolysis also is present in about 10 to 15% of patients with myelofibrosis. So, of course, we have to diagnose and treat coexisting causes and provide supportive care with red blood cell transfusion. But then the proposal by NCCN is also to rely on the serum EPO level with a cutoff of 500 milliunits per ml. And if it's lower than that threshold, to propose first ESAs or a clinical trial. And if it's higher, there's a series of drugs that are proposed here that could be, all of them off-label to my knowledge: danazol, lenalidomide or thalidomide with low-dose prednisone, luspatercept, or a clinical trial. So I will just give you first an idea of what can we expect from the JAK inhibitors that are currently available, ruxolitinib, fedratinib, and those, at least in Europe, that are not yet available in clinical practice, which are pacritinib and momelotinib. As you know, all these 4 JAK2 inhibitors also have other targets, and including JAK1, of course, but also TYK2, IRAK1, FLT3 for some of them. But one of particular interest for anemia is ACVR1, which is inhibited by momelotinib and pacritinib. What is ACVR1? ACVR1 is also named ALK2, and it's a receptor which is not on the surface of hematopoietic stem cells, but of the liver cells, on hepatocytes, and that controls the production of hepcidin. So when you block ACVR1, you reduce the level of hepcidin and you make the iron available for erythropoiesis and improve erythropoiesis. So these drugs, momelotinib, for example, first blocks not only JAK1, JAK2, but also ACVR1, and then this was the rationale to show some improvement in anemia with this drug. And this was recently demonstrated in the phase 3 Momentum study that included patients with myelofibrosis previously treated with a JAK inhibitor and who had anemia defined by an hemoglobin level less than 10 grams per deciliter. And patients were randomized to receive blindly either momelotinib or danazol, with an evaluation at 24 weeks for the primary endpoint, which was the response rate on the total symptom score, or TSS, with key secondary endpoints that were the transfusion independency rate, TI rate, and the spleen volume reduction, the SRR, at week 24. So in this study, what we could see is a clear superiority for momelotinib compared to danazol in terms of transfusion independence that was reached at 24 weeks by 31% of patients in the momelotinib arm. That was, not inferior than what was seen with danazol at 24 weeks of 20%. On the right, you can see the evolution of hemoglobin. And what is striking is a very rapid increase in the hemoglobin level. You can see after less than 4 weeks of treatment in the danazol arm in blue, with an increase from a median of 8 grams to about 9.5 grams, that remains pretty stable, as you can see, over time up to 48 weeks. In contrast, patients treated with danazol also have a smaller increase in their hemoglobin level at the beginning of the trial, and at the 24 weeks endpoint, they could switch to momelotinib for those who, and you can see that after 48 weeks, they can reach the same level as those who started on momelotinib upfront. So this is also possible to have this response after danazol. The second JAK inhibitor that also blocks ACVR1 is pacritinib. That was tested, you remember, several years ago in 2 large phase 3 trials, PERSIST-1 in patients without prior JAK inhibitor, and in PERSIST-2, which included patients who were previously treated with a JAK inhibitor, so a second-line trial, and the patients were randomized to receive pacritinib or best available therapy at 2 different doses for the PERSIST-2 study. So I will focus just on the response about hemoglobin and anemia in these trials, and in particular in PERSIST-2 in patients who were previously exposed to JAK inhibitor. You can see that there was a clinical improvement in hemoglobin levels in patients who were anemic at baseline, seen in 25% of patients after 24 weeks in those treated with pacritinib, compared to 12% only in the best available therapy arm. And again, for in terms of reduction of the transfusion burden for the patients who were not, of course, transfusion independent at baseline, a similar proportion, almost 22%, had a reduction in their transfusion burden on pacritinib compared to 9% only in the best available therapy arm. So these are the data for the JAK inhibitors, and I will let Aaron discuss with us other drugs that may improve anemia in the context of myelofibrosis.
Thank you. So let's talk a little bit about pelabresib. So BET proteins, I think, are certainly of interest within the disease. This is not a new target at all in the myeloid malignancy space. There have been other studies done in MDS and AML looking at BET inhibitors as potential treatment for those diseases as well. But there's a increased interest in BET, certainly in the myeloproliferative neoplasms, because of its key role in NF-kappa B. So NF-kappa B is a key pro-inflammatory pathway within the disease, and we think is a key regulator of disease pathogenesis, particularly in myelofibrosis. And so not only pelabresib, which is a selective oral BET inhibitor, is being developed, but several other BET inhibitors are entering clinical trials too, and have begun phase 1 trials. So here's this in a picture format, if you will. So I think a lot of us on the call are quite familiar with JAK-STAT being the kind of the key dysregulated pathway within myeloproliferative neoplasms, where there's a cytokine receptor like the EPO receptor that ultimately signals through JAK-STAT to affect its downstream effects. But as I mentioned, NF-kappa B is a key downstream mediator of that process that can lead to aberrant erythroid megacytic karyocytic differentiation, increased cytokine production, fibrosis, and ultimately improving cell survival in concert with these other targets like TGF-beta, BCL2, and c-Myc. So a lot of these 4 kind of key downstream effects, I mean, are being targeted in multiple different trials, not just BET. But upstream of that, again, is BET. So BET is a part of this kind of DNA reading complex that turns on these other processes downstream. So if we can kind of hit things with both JAK inhibitors and BET inhibitors, we might really be able to pinch this overactive process within these cells, leading to improvements in all the clinical pathology that we see within myelofibrosis. In preclinical models, putting BET inhibitors and JAK inhibitors together in a petri dish with myelofibrosis cells have really kind of been remarkable. And on the heels of that, have come the clinical trials. And the trial that we've been kind of keeping a close eye on is the phase 2 MANIFEST trial, namely because pelabresib is the furthest along in development, I would say, above the BET inhibitors. And the manifest trial has been reported out in a couple of different fashions at different congresses, but the way the study was designed, similar to the Luspatercept trial, looked at different subsets of patients with myelofibrosis, both in the second line as well as in the front line, as well as some patients with essential thrombocythemia. So in the second line, there were two kind of main arms, one where patients were no longer on ruxolitinib and pelabresib was added as a single agent. Just give pelabresib to see what responses we could see with that. And then there was the add back strategy arm, as arm 2, where patients were on Rux, but it wasn't doing well for them, maybe not maximizing the spleen or symptom response, and pelabresib was added on top to deepen responses or regain responses. The arm that really caught a lot of folks' eyes was this arm 3, which was frontline setting. So in patients who have never received a JAK inhibitor before, they received the combination of pelabresib and ruxolitinib. And this is a pretty new thing. I mean, of the approved agents, we do not have a combination therapy in the upfront or, quite frankly, in the relapse refractory setting. So there's a lot of interest in that. And then again, I mentioned there was an ET arm. So that included patients with essential thrombocythemia treated with pelabresib monotherapy. And the results from that arm were recently reported by Dr. Rampal at the ASCO meeting just earlier this month. So looking at arms 1 and arms 2, these are patients who had prior JAK inhibitor or ruxolitinib treatment. And pulling, since we're just focusing on anemia, I'm not going to focus so much on spleen volume and symptom burden response, but really focusing on that anemia response. And we were actually observed in this study improvements in anemia in these folks. So we see increases in reticulocyte count, those immature red blood cells, meaning increased erythropoiesis, as well as drifting up of the hemoglobin over time. It isn't something that's quick. Again, like luspatercept, you can see those responses quite quickly, but a general improvement over the duration of the study, albeit the numbers do trail off in the numbers of patients as the cycles go along, but an increase in hemoglobin level. And so if we kind of look at that average hemoglobin increase of 1.5 grams over 12 weeks, so a similar endpoint that we saw with in the luspatercept study, in the monotherapy arm, this cohort of non-transfusion dependent patients, there was a 59% of the patients did have this increase of 1.5 over 12 weeks. And then the add-on, so where patients were on Rux, stayed on the Rux, got pelabresib on top of that, almost 18% of patients had 1.5 grams increase in their hemoglobin. So responses were measurable in this study with respect to anemia. And again, that kind of goes back to the mechanism of action of BET inhibitors. If we can kind of force down the NF-kappa B expression, this can lead to better marrow function and improvement in the hemoglobin. And on top of this, there are other agents that are being developed to attack anemia. As I mentioned earlier, anemia is multifaceted, so we need lots of different ways of getting after anemia. So anti-hemojuvelin monoclonal antibody, so that is really kind of going at the hepcidin pathway. Hemojuvelin or HJV is a regulator of upstream effects of hepcidin. So by lowering hepcidin levels in patients with chronic inflammatory anemias like myelofibrosis, we can then improve iron shuttling and thus improve anemia in these patients. Other pathways, the SLAM F7 monoclonal antibody. So again, kind of in the ilk of luspatercept, kind of hitting those similar pathways, but at a different level. Dr. Kiladjian here also mentioned hitting ACVR1 and ALK2. So there are a number of drugs looking to act upon this pathway. And then IMiDs in general. So thalidomide, lenalidomide have shown anemia improvements in different trials. And we're trying to figure out ways to safely combine this with JAK inhibitors to improve anemia as well as control spleen and symptoms. So there's ongoing interest in this general pathway as well, the cereblon affecting drugs, or also known as the IMiDs, like thalidomide, lenalidomide, and the like.